Now, as I promised, I'm going to share some financial and personal information about my clinic because I think it will help you to understand certain key issues that must be addressed in upcoming reform. And a radiology clinic is a good example, I think, because it's in our radiology departments where we have cutting-edge technologies that everyone wants and needs, but which also represent a large chunk of the healthcare expenditure in our country because these exams are so expensive. For example, a treadmill stress thallium exam might be billed out at $7,000 or $8,000 for just the one exam, or a PET scan might be $5,000 for one exam. Let's take a look at why these exams are so expensive and also why those prices are overly inflated. To try and keep this video as short as possible, I won't go into any detail on this slide, but these are the major expenses to get our clinic going, including having to buy a $1.2 million MRI unit. You can read these other expenses if you choose, but bottom line is there's a great expense in getting a radiology clinic or radiology department or hospital going. And I've owned this clinic for over 6.5 years now. I know these expenses well. I also know that we need about $800 or $900 per exam to keep this clinic successful. And by successful, I mean the ability to pay our bills at the end of the month and also put away enough money in the bank so that we can upgrade the clinic in a reasonable period of time or have money to deal with an unexpected expense that might come along. And let's look at what a patient gets for that $800 or $900. It includes performing the exam, a radiologist on site supervising that exam as it's being done and customizing it as necessary. As soon as that patient gets out of the MRI suite, they sit down with that radiologist for a 10 to 30-minute consultation to assure that all of their concerns were addressed in that imaging and that those concerns make their way into the final report. Then a copy of the examination is provided to the patient on computer CD, not with the final report, but just their images so they can keep them for the medical record. Then the examination is interpreted, a report is faxed to their physician, and we do all the filing of the insurance. I say this not to brag about all the services we do in our clinic, but to emphasize the point that this is probably more service than you can find anywhere in your area, and we can do this for $800 or $900 per exam. However, a typical private insurance reimbursement to our clinic is $500 to $650, significantly less than what we need. The average Medicare reimbursement is $456, about half of what we need. And the average Medicaid reimbursement is $280, about a third of what we need per exam. So we don't charge $800 or $900 per exam, we charge at least $1,650, maybe $1,850 per exam. And I can tell you, we barely get by. And I'll tell you, most clinics, most hospitals charge closer to $2,500 to $3,000 per exam and provide even less service than what we do. Now look at what would happen if we had a different insurance system. Let's look if we had a single-payer, not-for-profit insurance system, and that insurance system reimbursed medical services with a realistic payment. If we were reimbursed $800 for having provided an exam as long as we meet basic quality standards, or if we were paid $900 if quality were exceptional, we would be ecstatic. We would immediately reduce our charges to this new lower $800 to $900 amount, a reduction in our cost by about 40%. Now consider that on a more global scale. In 2009, healthcare expenditure is expected to be about $2.4 trillion for this year. A 40% reduction of cost would be $1 trillion. Now that's a little bit unrealistic because not all healthcare expenditure is to hospitals, clinics, and physicians, but we're still talking about hundreds of billions of dollars saved every year. And you might ask yourself, where is the increased money going to come to increase the medical reimbursements that you're talking about? Because pretty much across the board, payments are going to have to go up by about 40%. The bulk of this money is going to come from keeping healthcare dollars within healthcare and no longer allowing these insurance companies to take all this money for their profit and their pleasure. Keep it in healthcare. And it's also going to come from savings in other changes discussed in upcoming slides. But it's not going to come from limiting Medicare services. It's not going to come from contributing to our national debt. And consider this new payment system I'm talking about would promote quality because you're paying less for basic quality, you're paying more for high quality, so it promotes quality. And it would need safeguards to not reward quantity. The administrative simplification would be massive. Instead of maybe 1,000 different insurance companies from coast to coast offering thousands of different plans, we would predominantly have only one. And now imagine other aspects of healthcare reform, electronic medical records. Now these are going to facilitate communication between our physicians, hospitals, and clinics and help prevent waste and confusion. They can allow portability and ownership of patients' medical records, which is huge. So let's say you live on the East Coast, you go to the West Coast for vacation, you get into trouble, you wind up in a hospital. Let's say that physician can just type in the computer, punch in a code, and all of a sudden have access to all of your past medical records, doctor's notes, lab values, imaging, the actual images, all right there at their disposal immediately so that they can know you, know your medical history, and move on quickly and accurately with your care then. It will also allow better tracking of your medical record over time, and this is important because often medical records are either not known or they're lost, which is bad because you need to be able to look back over the medical record in the past so that you can see any changes as they develop. Electronic medical records will also help establish and track treatment protocols. So protocols that we think are effective, we can track on a nationwide basis and make sure that they really are effective, and if they're not, drop that and move on to something that is. And it will also be very important for ongoing medical research. So electronic medical records are huge. They also will facilitate electronic prescriptions. E-prescriptions have been demonstrated to have fewer prescription mistakes, and it would also help track prescriptions and not allow drug abuse as much. Medical liability reform, tort reform. That means less defensive medicine, lower cost of malpractice insurance, greater confidence in our doctors and our health system. Preventive medicine, there are all kinds of measures here in reform. Most of you know Dr. Oz because he's been on the Oprah show several times. He talks about nutrition. He has wonderful ideas about nutrition. He has wonderful ideas about developing a health corps. You may recognize the name Dr. Hyman, again a wonderful physician who specializes in functional medicine, a realm that has great ideas in preventive care and also novel approaches at healthcare in general. And there are many other individuals like this who have great ideas. Under preventive care, we're talking about universal use of recommended screening, nutritional reform, such as that recommended by Slow Food USA, and then they're talking about revamping the Child Nutrition Act and our school lunch programs, and etc. Also, preventive medicine means reform within our medical education to promote this new paradigm of health promotion and disease prevention. Another aspect of reform, coordination of services. Dr. Nokomovitz from Cleveland Clinic testified before the Senate. He gave examples of coordination within their clinics and hospitals, maximizing efficiency and utilization of our allied healthcare professionals and primary care physicians and specialists. And the Mayo Clinic had similar testimony. And we need to follow their examples to increase efficiency within our health system. Pharmacy reform, largely cost containment. And no healthcare reform is going to be complete without universal coverage to its citizens. We all need healthcare insurance. We all need equal access to our health system. And as the increased patients come into our health system, we have to address our physician shortage, which means federal lifting of spending caps on medical education and promoting our medical schools and residency programs and giving incentives for individuals to go into primary care, especially into rural primary care. These changes are exciting. We need all of these changes to take place and more. Basically, once this framework is laid down, we need the powers to be to step aside and allow experts within the field to make refinements and further suggestions and basically allow this thing to grow as a national health reform movement. And the result will be the best health system that we can have, and probably the best health system in the world. But before reform can fully be implemented, we must first make this foundational change to our insurance system. We have to exercise high intellect, high morality, and raw Western guts in order to do the right thing and lay down this foundational change to our insurance system and create a single-payer, not-for-profit health insurance that covers most of what we do in healthcare, which would then make the for-profit private insurances something supplemental on the sideline. Surely it's not debatable that the status quo must go away, that is bringing down our health system, that is bringing down our national economy. They need to be put aside. That's not even an option. One option is the public option. To me, it's not an option at all. To have a public option is to say we're going to keep these for-profit health insurance companies in the forefront of our health system and just compete with them to keep them honest. Keep them honest. As long as they're in the forefront of our health system, they're going to be doing everything they can to generate profit, and as they do so, it will be to the detriment of your health and to the detriment of our health system and our nation, and that's the exact opposite of what we need in our health system. So to me, even a public option is not an option at all. What is best is to create this single-payer, not-for-profit health insurance system. However you want to set it up, that can be debated, but it is this which is greatest for our nation, best for our health system, and best for your family. But Congress will not do this on their own. They shouldn't do it on their own. They do what we tell them to. And so far, we've not told them what we want them to do. So they are floundering with dramatics along political lines, and they will not do the right thing until we tell them to. So you and I need to make up our mind, decide what is best, and then we need to tell them. We need to be very vocal. I hope you agree with me and other physicians that this is the best for our country, and then make yourself heard. We need to do so in great numbers. Basically, for Congress to act on what we tell them to do, it needs to be more or less the majority of the population, which we're talking about 150 million people or more. But why not? This is a communication age. Pick up your phone, make a phone call. You can do it on your own, or you can wait for me to contact you. I've got some ideas how we can do this in creative ways, based on large groups making phone calls at the same time. Basically creating a civil disobedience. But why not? We need to be heard. We need to make a public stir. We need to make ourselves heard so that Congress can then do the right thing, and then we can move forward with meaningful reform.